Welcome to myeyeacademy.com. I'm Professor Mahfooz from Jinnah Medical College, Pakistan. Myeyeacademy.com is the unique platform for ophthalmic teaching for doctors, paramedics, and patients. We discuss keratoplasty in this lecture. Keratoplasty is also known as corneal graft or corneal transplant. In keratoplasty, abnormal host tissue is replaced with a healthy donor corneal tissue. The four common indications for keratoplasty are keratoconus, which is protruding of the cornea, which causes the defocus image, so it needs to be replaced with a clear cornea. Second common indication for keratoplasty is corneal opacity, which is most commonly secondary to a corneal infection. Pseudophakic bullous keratopathy is another indication in which the corneal endothelium is damaged and the cornea cannot pump out the water and gets waterlogged and causes the pain and decreased vision. And the fourth common indication is corneal dystrophies and degenerations. All these four indications are called optical indications for the keratoplasty. So keratoconus, corneal scarring, bullous keratopathy, and dystrophies, they are all the optical indications for the keratoplasties. Second common indications for the keratoplasty are therapeutic indications, in which the most common is corneal ulcer, or corneal ulcer which cannot be treated with topical or intrastromal medications, sometimes needs therapeutic keratoplasty to remove the diseased tissue and to replace it with a healthy one. The third group of keratoplasty is tectonic keratoplasty, in which stroma is either thin like in a desmetocele, or it's very thin at the periphery because of stromal thinning, and it needs to be replaced with a healthy tissue. The fourth and rare indication for keratoplasty is cosmetic, in which the eye is white and cosmetically not good looking, so it needs to be replaced with a healthy cornea to be cosmetically acceptable. Now, the surgical technique. Here, this is a donor cornea in which the stroma is represented in yellow, while this is a recipient cornea in which all the layers are represented in light brown. Now, the top layer is corneal epithelium, then the Bowman's membrane, stroma, Descemet membrane, and endothelium, and same is for the recipient cornea. Let's go to the next slide. Surgical technique. Now look at that. Here we have cut the cornea through and through, means all the 5 layers are being penetrated, so this is called penetrating keratoplasty. In the other 3, the cornea is partially penetrated, the top 3 layers are penetrated, while here the bottom 2 and part of the 3rd layer is penetrated, while here only the bottom 2 layers are penetrated. So all these 3 are called non-penetrating keratoplasty. So surgically, keratoplasty can be either penetrating keratoplasty or non-penetrating keratoplasty. Let's see that in detail in the next slides. Now, the corneas on the left hand side are all the donor corneas, and corneas on the right hand side are all the recipient corneas. Now look at the top one. Here the cornea is fully penetrated, and we are going to replace all the 5 layers from donor to the recipient cornea, and this is called penetrating keratoplasty, or shortly PK. In the second one here, the top 3 layers are being penetrated and separated, and these are transplanted into the recipient. Now this is called deep anterior lamellar keratoplasty, or simply DALK, in which the epithelium, Bowman membrane, and the stroma is replaced in the host. In the next one, Descemet membrane and endothelium with some part of stroma is transplanted into the recipient, and this way of doing keratoplasty is called Descemet stripping automated endothelial keratoplasty, or DSEK. And finally, only the bottom 2 layers, which is endothelium and Descemet membrane, are taken from the donor and being transplanted into the host, and this is called DMAC, or Descemet membrane endothelial keratoplasty. So the top one, this one is penetrating keratoplasty, and bottom 3, They are all non-penetrating keratoplasty in which the cornea is not penetrated fully. This one is called DALC for the anterior layer, and DSAC and DMAC are for the posterior layers. Now the prognostic factors. There are some prognostic factors which actually tell you that the keratoplasty results may not be very good, and these are abnormalities of the eyelids, which needs to be corrected first. If there's a TF film dysfunction, that needs to be addressed before doing keratoplasty. Conjunctival inflammation, severe corneal vascularization, absence of corneal sensation, extreme thinning, corneal inflammation, anterior synechial uveitis and glaucoma, all these needs to be addressed before doing keratoplasty, otherwise there are more chances of keratoplasty to be failed. Post-operative complications, there are early complications and late complications. In the early complications, there are persistent epithelial defects, protruding sutures, papillary hypertrophy, iris prolapse through the wound, increase intraocular pressure and infection, and early graft failure, which usually recovers. In the late complications, there is astigmatism because of the suturing. The corneal shape is not very good, but that needs to be corrected and can be corrected with further surgeries. There could be late wound dehiscence or separation, recurrence of the initial disease in the graft. A membrane can be formed called retrocorneal membrane, or the patient can develop glaucoma, cystoid, macular edema, which can be treated, but the main complication is late corneal graft failure, which needs to be addressed and can be treated with topical and systemic. Thanks for being with Professor Mahfooz at myeyeacademy.com. Please do like, share, download and subscribe the channel to see more videos. Thank you.